Sí, ya está, doctor. Ahora se lo doy.
¿Ya está hablando o está en prueba?
Sí, no, yo creo que está en prueba porque se escuchó y ya de repente ya no soy yo. Pensé que era el volumen de aquí, pero no. Y aquí tiene el audio activado, entonces no sé si sea de allá o…
Háblale. Pregúntale que ya te comentaste. Es que ahí se ve de todos modos.
Ah, ok. Entonces aquí, ¿cómo le hago?
Léale. ¿Atrás, no?
No.
Sí, ya. Está en el recuerdo.
Cuando así se requiere. Entonces, yo quiero invitar a Alejandro. Alex, por favor, ven aquí, acompáñanos y platícanos, por favor, un poco de COSADIM, de GC1, de lo que estamos haciendo en estas iniciativas, no sin antes reiterarte a ti y a Juan Carlos Molina, el director general de GC1, nuestro agradecimiento tanto por invitarnos a formar parte de este gran evento de The Issue, que tuve la oportunidad de asistir el año pasado, como también para empezar a construir esta alianza, no solo a través de la COSADIM, sino de forma directa COSADIM con la Comisión de Salud del Consejo Coordinador Empresarial. Muchas gracias nuevamente, Alex.
Al contrario, Patrick, muchísimas gracias a ti, muchísimas gracias al Consejo Coordinador Empresarial por estar en este evento de The Issue. La verdad es que para mí es bien importante y bien gratificante el poder estar platicando con ustedes. Hace rato había 22 conectados, creo que ya incrementó un poquito, pero sí es bien importante, y como bien lo decías, lo más importante de todo esto es la colaboración. Y eso es lo que hacemos en GC1. Dices, gracias por la invitación, yo te agradezco a ti toda la colaboración.
Ah, sí, ya se escucha.
Vas ahora a tener la oportunidad de transmitir lo que es GC1 al CCE, y que en un momento dado nos vean como un aliado, como un amigo, como alguien en quien se pueden apoyar y con quien podemos desarrollar proyectos conjuntos. GC1, ¿qué es GC1? Somos una asociación civil sin fines de lucro, y creo que lo más fácil y como más nos recuerdan es el código de barras. Hace 40 años nosotros empezamos ordenando el código de barras. El código de barras data de hace mucho más tiempo. Y aquí lo importante es que cada quien jalaba agua para su molino, algo muy parecido que está pasando ahorita te sonará parecido, Patrick, pero eso es lo que está pasando ahorita en el sector salud. ¿Y a qué voy? Que en ese entonces, hace 40 años, si tú le vendías un producto a Aurrera tenía sus propios códigos de barras, sus códigos internos. Pero si tú le vendías un producto a Comercial Mexicana tenía sus propios códigos de barras. Entonces, para los fabricantes, imagínense lo complicado que era tener un lote para Comercial Mexicana, tener otro para Gigante, tener otro para Aurrera. Entonces, por eso nace GC1, para tratar de estandarizar. Y de esa forma se estandariza lo que es el código de barras. De tal forma que ahorita pues nosotros ya tenemos un solo código de barras que es único e irrepetible a nivel mundial. Y eso mismo es lo que pretendemos, y por eso es que GC1 estamos ahorita platicando dentro del sector salud, porque fue hace 3 años que empezó The Issue, pero empezamos con una agrupación bien variada como lo tenemos ahora, donde queríamos que estuvieran todos los que tuvieran que ver algo con el sector salud y sobre todo con el sistema o el ecosistema digital, como le hemos hecho llamar. Entonces, ¿qué es lo que hemos visto? Hace un año iniciamos nosotros y queríamos hacer una
prueba. Y ahorita ya lo van a enlazar, doctor, porque están haciendo la prueba.
Médica electrónica, expediente clínico electrónico, la teleconsulta. Sí, y bueno, nos dimos una grata sorpresa de que todo eso ya funciona, de que todo eso ya está jalando.
Sí, leo que
Simplemente lo que sucede es que si nos vamos a un hospital, no quiero decir marcas para no comprometerme con nada, pero Cada uno de esos hospitales tiene su propia receta médica electrónica o tienen un expediente clínico electrónico. Y dentro de esos grandes hospitales hay veces que inclusive el área de diagnóstico no se habla con el área de check-up y no se habla con el área de doctores. Entonces, si tú vas a una misma institución hospitalaria, te hacen tu expediente clínico, posiblemente en urgencias, y luego te hacen otro en el check-up, y luego te hacen otro con el médico que vas, inclusive si tienen dentista, te hacen un nuevo expediente clínico electrónico. Entonces, todo eso funciona y funciona muy bien, pero ¿qué es lo que pasa? Que no hay comunicación entre ellos, no hay interoperabilidad. Y si no lo hay dentro de una misma institución, imagínate cuando queramos meter aquí a aseguradoras, a doctores, o sea, todo lo que implica en este ecosistema, realmente la comunicación va a ser bien complicada. Entonces, aquí estamos para colaborar, o sea, bienvenidos a GC1. Lástima que lo hiciste virtual, Patrick, pero nos encantaría poderlos tener aquí, y aquí estamos. Ya vieron que tenemos unas bonitas instalaciones para poder recibir aquí al Consejo Coordinador Empresarial, que hagan aquí su asamblea, que nos conozcan, y por qué no también presentarles los diferentes productos que tenemos dentro de GC1.
Pues te vamos a tomar te vamos a tomar la palabra, mi querido Alex, no te me vayas porque te tengo otra pregunta. Espero que nos estás invitando sin renta, ¿verdad? Nos podemos...
Sin renta. Depende de lo que quieran hacer. El foro, así como lo ven, es propiedad de GC1, pero está al servicio de todos ustedes y lo platicamos. Ya si te quieres traer un show o algo, pues ya eso sí ya lo platicamos. Pero no, la verdad es que es un foro de colaboración y lo que más nos gusta es que vengan, que nos conozcan y que vean que GC1 es más que un código de barras. Ya me eché el comercial, pero bueno.
Oye, y te quería preguntar, porque, a ver, viéndolo desde el punto de vista más simple y sencillo, lo que estabas mencionando es, podemos soñar en 1000 cosas cuando hablamos de salud digital, pero si bajamos esto a consulta, expediente y receta digital, yo lo que me estoy imaginando es que, por ejemplo, los laboratorios y dispositivos empresas de dispositivos médicos podrían tener el acceso a información, obviamente no la información personal y privada de cada persona, sino en el agregado para poder mejor planear su abasto, su fabricación, y creo que eso se refleja en costos, en mejor surtidos, la distribución más eficaz. También pienso que las autoridades podrían, si tuvieran acceso también otra vez en el agregado a la información de lo que se hace en sus instituciones públicas como también las privadas, incluyendo en las CAFs de las farmacias, podrían tener una mucho mayor precisión y oportunidad en los datos para identificar riesgos epidemiológicos, identificar también, oye, dónde estoy surtiendo, dónde no, y poder resolver temas, deficiencias o áreas de oportunidad. 3, yo creo que desde el punto de vista del paciente, pues creo que lo que más flojera me da es tener que ir a una institución, levantarme bien temprano, me siento mal y a ver si alcanzo ficha, a ver a qué hora me pasan. Entonces, si de primera instancia, entendiendo que tal vez más o menos el 80% de los casos de primer nivel de contacto se pueden resolver ahí, pues tal vez con una teleconsulta, ¿no?, se puede atender, y yo como institución pública o privada puedo mejor aprovechar mi capacidad instalada y no consumir tanto de ella en ese primer contacto que, reitero, no necesariamente necesita una visita presencial. Capturo los datos en el expediente y si le enchufo algo de inteligencia artificial que de verdad no es nada fuera de este mundo ni caro, puedo empezar a hacer 1000 cosas con esa data. Y por el otro lado, la generación de esa receta, pues yo como paciente puedo optar por ir a donde sé que está el inventario, o puedo optar por una que me lo manden a mi casa, o puedo ir al lugar que me lo vende más barato. Entonces, estoy diciendo una cantidad de cosas que se me están ocurriendo ahorita en caliente de lo que podría aprovecharse solo si aprovechamos o echamos a andar lo más elemental que es telemedicina en su contexto amplio. ¿Qué opinas tú de eso?
Fíjate, me estabas haciendo una pregunta y realmente se volvió una explicación de exactamente lo que podemos llegar a hacer, porque a través de teleconsulta, receta médica electrónica o expediente clínico electrónico podemos tener una información de gran valor. O sea, podemos detectar inclusive epidemias, podemos detectar dónde se está dando una cepa de algo para poderlo atacar, para ser más eficientes con la distribución, con los medicamentos, realmente para todo. O sea, el valor de la información aquí es infinito, y me das el cue para pedirles que se queden a la primera plática. Bueno, ojalá se queden con nosotros todo el evento, pero GS1 es una asociación a nivel mundial y hoy tenemos la oportunidad y trajimos a un speaker de GS1 UK que nos va a platicar el caso de éxito que se ha tenido precisamente en Reino Unido. Ellos llevan ya 20 años trabajando con algo que nosotros queremos lograr, que es precisamente esa interoperabilidad, ese uso de los datos, ese uso de la comunicación, esa colaboración. Entonces, a las 9 vamos a empezar aquí con la inauguración de este evento y calculamos como 9:15, 9:20 vamos a tener la participación de Chris, que viene directamente de Londres, para darnos una plática, y vamos a tener oportunidad de preguntarle todas esas cosas porque él es experto, él ya lo vivió. Algo bien diferente que tienen con respecto a México es que el 90% de ellos es la atención médica por parte del gobierno. Entonces cambia radicalmente, pero hay mucha información. Después de eso vamos a tener un panel en el que vas a estar participando y vamos a ver precisamente todo ese tipo de oportunidades. También vamos a tener a Bruno, que nos va a hablar de cómo nos ha ido con la receta médica electrónica. Entonces va a estar bien interesante este día. Entonces, por favor, quédense con nosotros.
No, pues, Alejandro, te agradecemos muchísimo nuevamente esta invitación. Y antes de que pasemos ya al inicio de este evento, la inauguración del mismo, quisiera preguntarle a Omar, no sé si tenemos algunas preguntas de parte de quienes nos están acompañando virtualmente para que las podamos desahogar antes de pasar al siguiente bloque, por favor.
¿Me abres? Sí.
Si alguien tiene una pregunta, por favor levanten la mano ahí en la plataforma virtual y Omar les va a ir abriendo el acceso para poder comunicarnos la duda o hacer su comentario.
Sí tenemos gente que había levantado la mano, pero ya la bajaron. Solo decían que se estaba metiendo a la prueba de sonido de Oscar Zavala, pero ya lo silenciamos. Es lo único. A ver, vamos a ver. Juan Carlos Castillo,
¿alcanzaste a escuchar?
levantó la mano.
Creo que están haciendo prueba de sonido, ¿no? Entonces no se puede ahorita, Omar, porque aquí tenemos una pregunta en presencial. Igual empezamos por acá.
Sí, si gustan.
Si me ayudan con un micrófono.
Sí, comencemos con las preguntas presenciales
por
ya
favor.
de ahí.
Aquí, por favor.
Hola, buenos días. Soy Miguel Ortiz de Instrumedin y de la revista Salud Premium. Yo quiero saber si esta iniciativa que está teniendo va a tener alguna coincidencia con la Agencia de Transformación Digital que va a dirigir Pepe Merino. Y si esa es la intención, porque bueno, pues ya vimos el trabajo que acaba de hacer el expresidente Cofepris con esta nueva tecnología de formatos digitales en DigiPris y pues esta transformación que está alcanzando a las dependencias de gobierno y pues también obviamente la unificación de estas plataformas digitales en toda la médica privada.
Pues qué buena pregunta nos haces, y sujeto a lo que ahorita me complementa Alejandro, te puedo compartir que desde el principio del sexenio pasado, la Comisión de Salud del Consejo Coordinador Empresarial, junto con los 14 organismos que conforman CCE, nos hemos ido sentando frecuentemente con las autoridades en Cofepris. Y ya en el momento que estuvo liderando el doctor Alejandro Sbarch, él realmente se puso la camiseta, o sea, compró el boleto de que una de las maneras más eficaces de poder resolver o ir resolviendo en el tiempo todo este rezago de trámites que tienen dentro de la institución, como también para darle más transparencia a esos procesos, era iniciar una plataforma de digitalización. Y de ahí DigiPris, que tú mencionas, creo que le falta todavía muchísimo. Creo que la oportunidad mayor viene no solo en digitalizar procesos para que las industrias reguladas puedan accesar a la institución e iniciar sus trámites. Esa es una. La otra, que es la más retadora, que todavía falta, es que esos procesos se digitalicen adentro de COFEPRIS, para que entonces el proceso también desde ese lado, la cancha también fluya más rápido. Entonces, pero yo te lo puedo confirmar, el doctor Sbarch en su momento está convencido de continuar en ese proceso y no tengo la menor duda que la siguiente administración en COFEPRIS, que todavía no sabemos el nombre, también va a continuar por esa ruta. Y contestando el segundo punto que fue tu primero, sí tenemos pendiente justamente a partir de este evento tomar los resultados de este mismo y como documento sentarnos con Eduardo Clark para poder iniciar o desarrollar una agenda en común, para que podamos contribuir a que se vayan definiendo el marco referencia con el cual se va a facilitar esta adopción. Pero totalmente de acuerdo y sí, de eso se trata el día de hoy. Alex, no sé si quieres complementar.
Pues creo que ya lo mencionaste todo, pero parte del evento y prácticamente como a las 11 de la mañana vamos a querer escucharlos a todos ustedes, todas esas opiniones, porque como dice Patrick, vamos a crear un documento muy sólido para ver en qué forma podemos colaborar como industria privada con el gobierno, que es toda nuestra intención, la verdad. De hecho, hoy teníamos la visita del subsecretario, lastimosamente nos canceló hace ratito, porque lo llamaron en presidencia, entonces donde manda capitán no gobierna marinero, pero creo que ese es un buen acercamiento para tener la claridad de que ellos están con COSADIM, Coalición por la Salud Digital de México. Entonces realmente vamos avanzando. Vamos a tener a un representante de la Secretaría de Salud que nos va a dar unas palabras que también nos va a ayudar para entender el cómo se va a trabajar, cómo vamos a ir avanzando en este tema y sobre todo la participación de todos ustedes, como decía Patrick, para fortalecer un documento que nos ayude a llegar más fuertes, más unidos, de tal forma de poder colaborar con el gobierno.
No sé si tenemos alguna otra pregunta, tanto presencial como en quienes nos acompañan virtualmente.
Sí. Juan Carlos Castillo tiene la mano levantada, ya le dimos acceso. Por favor.
Muchas gracias. Primeramente,
Juan Carlos, bienvenido. Adelante,
gracias,
por favor.
Gracias, mi querido Patrick. Felicitarte a ti, a la Comisión de Salud del CCE y a Alejandro de GC1 por esta gran iniciativa. Mi pregunta, comentario va muy aunado justo a lo que acaban ustedes de comentar, la construcción de una política pública que esté relacionada con la obligatoriedad que pueda tener el Estado mexicano para garantizar la salud digital, pues más allá del tema de etiquetado, capitalizando o aprovechando toda la infraestructura, como ya se mencionó previamente, que permita tener mucho más eficiencia en la prestación de los servicios de salud. Creo que sería importantísimo entender cuál va a ser la postura que va a tener ahora en esta intención la Secretaría de Salud como órgano rector de la decisión sanitaria nacional, junto con el resto de las entidades colaboradoras e instituciones prestadoras de servicios de salud, pero más allá de la implementación que pudiera tener la Agencia Regulatoria Sanitaria Mexicana, COFEPRIS, se está previendo alguna instancia de construcción en donde todos los actores, tanto hacedores como decisores de la política pública sanitaria, puedan de alguna manera unirse a este esfuerzo a través incluso de la propia coalición, para que sea la salud digital, la tecnología en salud, sea una garantía y un derecho a la cual los pacientes puedan acceder?
Juan Carlos, esto que acabas de mencionar es literalmente el endgame, es a lo que queremos llegar y tú seguramente serás una pieza clave, un actor que junto con todos los demás que nos están acompañando va a contribuir a que esto se vuelva una realidad. Lo que pretendemos hacer sí es tratar de generar una sola línea discursiva como propuesta integral de parte del sector privado. Esa es la intención de lo que ha hecho CCE, la Comisión de Salud de CCE, como también se está haciendo a través de COSADIM con el apoyo de GC1, pero tú eres una parte de ello sin lugar a duda. Dos, quiero también enfatizar que la idea es tratar de definir ese común denominador mínimo al que le vamos a tirar, en el que todos estamos de acuerdo y que podamos avanzar, porque necesitamos ir con un discurso unificado, con una propuesta básica en la que la mayoría de nosotros coincidamos y con eso podamos aspirar a que trabajemos conjuntamente, tanto con la subsecretaría de Eduardo Clark, como también en la parte que sin duda alguna también aporta COFEPRIS con su regulación y normatividad, para que todos quienes decidan adoptar estas tecnologías se sepan que están en un espacio de cumplimiento y no cayendo en situaciones que les generen riesgos. Entonces, te agradezco la pregunta, te reitero la invitación para que nos acompañes y coadyuves en este esfuerzo, y sí, te reitero que esto que tú estás planteando básicamente es el objetivo final al que queremos lograr. Alex, no sé si quieras comentar algo.
Creo que ya lo comentaste todo y tú eres el experto en esto. Nosotros somos más para coordinarlos, para manejar estándares, y por eso es que está GS1 metido en esto. Muchas gracias.
Alex. No sé si tenemos una última pregunta. Acá tenemos una… Si nos pueden pasar el micrófono acá adelante. Adelante, por favor.
Buenos días, Patrick, buenos días, Alejandro. Aquí Luis Espinosa, de Mi Receta Digital. Desde la perspectiva de la Asociación HealthTech México, desde la Asociación Internet MX y desde luego de Mi Receta Digital, vemos a la transformación digital de la salud como la única forma de lograr los objetivos de desarrollo sostenible para el 2030 planteados por la Organización Mundial de la Salud. Me gustaría escuchar, Patrick, Alejandro, la visión de COSADIM, del Consejo Coordinador Empresarial, en este tema.
No, con mucho gusto, y le estás pegando al clavo ahí con lo que estás afirmando, y te voy a decir por qué. Tristemente tenemos una población del tamaño que tenemos, con un perfil socioeconómico, con todos los retos que ya trae, y además con una amplitud geográfica que, en combinación con un sistema de salud en el cual no le invertimos mucho de nuestro PIB versus otros países, que hoy tenemos tal cantidad de personas que no tienen acceso a la salud. Y acceso no solo quiere decir que estoy en la sierra y no tengo nada, es que puedo estar en una ciudad, ¿no?, en una zona urbana, y voy al hospital y sí hay un médico, pero no hay el equipo, o sí hay el médico, sí hay el equipo, pero no hay el medicamento, o cualquier combinación de esas. La manera que vamos a, de verdad, la manera más eficiente, el camino más eficiente para cerrar brechas de acceso no va a ser invertir de repente el 7% de nuestro PIB en salud. Ojalá lo logremos, pero la veo muy retadora. Más bien es invertir en tecnología. La tecnología es la que nos va a poder habilitar para que, por un lado, o sea, visto desde la persona, el paciente, quien debe estar al centro de todo lo que hacemos, le vamos a dar una mejor experiencia, una experiencia en la que vamos a poder implementar estrategias de prevención efectiva, monitoreo para detección oportuna de cualquier condición antes de que se vuelva crónica o algo catastrófico, y poder aprovechar, o sea, coordinar y aprovechar mucho mejor mi capacidad instalada. Desde el lado de las instituciones, sale muchísimo más barato, o sea, echar a andar estos proyectos de telemedicina, como mencionó Alejandro, ¿no?, con su teleconsulta, el expediente clínico electrónico y la receta digital, que levantar otro hospital, equipar ese hospital y contratar a todos los profesionales de la salud que se requieren. Va a ser mucho más eficaz. Entonces, no digo que no se invierta en infraestructura, urge crecerla y mantenerla, pero necesitamos invertir en tecnología, porque eso es lo que, reitero, nos va a dar mucho más, vamos a contribuir a que mucho más personas tengan acceso, y que ese acceso sea oportuno, de calidad, y que haya continuidad, o sea, ese monitoreo. Y reitero, va a haber con la misma también cambios en la eficacia de las estrategias de prevención, ¿no? En vez de comerciales y todo, realmente vamos a poder hacer algo que incida en el comportamiento y los hábitos de la gente. Pero bueno, creo que vamos ahorita sobre el tiempo, Alex, y no sé si hay algún otro comentario nada más para cerrar y poder arrancar con el evento.
Hay varias preguntas. Yo creo que por cuestión de tiempo nos vamos a una última, porque vamos a empezar el evento y realmente parte importante va a ser esta presentación que nos va a hacer Chris, que viene de UK, donde se van a contestar varias preguntas de las que están haciendo ahorita y después vamos a tener oportunidad de platicar. Entonces vámonos a la última pregunta para poder dar inicio al evento.
Buenos días, Lourdes Yáñez de la Federación Internacional de Salud Integral y Belleza Restaurativa. Primero, pues una felicitación por esta iniciativa. Yo creo que la clave está en sumar a todas las iniciativas que ya están en este tema, ya que hay mucha gente trabajando en la digitalización de la salud y también enfocarnos hacia el tema preventivo. Y otro tema que va a ser crucial es el logístico, porque una cosa es la receta, pero ¿quién la va a surtir si estamos en la sierra? Y estos son esquemas que tenemos que considerar. Y ya vimos también el tema de que la pandemia nos mandó a todos a casa. Creo que ese debe ser una parte sustantiva del enfoque que le tenemos que dar para sensibilizar tanto a las autoridades como a las personas de que no nos pueden tomar otra vez desprevenidos y poder disponer de este servicio para todos, ya sea en tiempos regulares o en tiempos extraordinarios como los que ya vivimos. Gracias, felicidades por la iniciativa.
No puedo estar más de acuerdo.
De acuerdo, pues realmente tampoco fue una pregunta, fue una muy buena aportación que vamos a considerar, vamos a tomar en cuenta. Entonces vamos a hacer un pequeño break de 5 minutitos nada más, o si tú quieres terminarla o dar la continuidad dentro del CCE y ahorita regresamos para inaugurar el evento.
Perfecto, pues amigas y amigos todos, reitero, les agradecemos muchísimo el que nos estén acompañando hoy en esta colaboración, este evento conjunto entre la Comisión de Salud del Consejo Coordinador Empresarial y GC1, la COSADIM, ¿no? Esta coalición para la salud o por la salud digital en México. Y en breves minutos arrancamos con nuestro programa. No se nos separen. Gracias.
No, sí, ya me escuché.
Es que yo estoy como secundario, ¿no?
Ajá, sí se oye ya su voz.
A ver. Mira, aquí sí tengo audio. Cristiana, pero. A ver. Apaga el audio.
Hola, hola, ¿cómo están? Nuevamente, bienvenidos, es un gusto tenerlos aquí, la verdad, en esta tercera emisión de The Issue. La verdad es que creo que estamos en el mejor momento para poder hacer un The Issue y para poder colaborar directamente con el gobierno. Creo que se están acomodando mucho las cosas y la verdad es que nos da mucha ilusión tenerlos a todos aquí. Ahorita, durante los 5 minutos de break que se dieron, tuve la oportunidad de saludar a muchos amigos y sobre todo a muchos líderes de la industria, y también me dio mucho gusto verlos a todos ustedes interactuando. Realmente creo que tenemos una gran comunidad y eso va a ser lo principal para poder nosotros colaborar, que es la palabra clave del día de hoy, colaborar. Entonces, ya platiqué mucho hace ratito, que era una sesión que teníamos para el Consejo Coordinador Empresarial de lo que es GS1. Entonces, no me queda más que darles la más cordial bienvenida. Disfruten del evento y sobre todo reflexionen en los diferentes temas que les vamos a estar presentando, de tal forma que al final de las exposiciones podamos tener una plática rica de qué es lo que debemos de hacer, de cómo debemos movernos y sobre todo cómo debemos de accionar. Creo que la mesa está puesta y vamos a iniciar el evento. Muchas gracias por estar aquí. Hay cortinilla.
Buenos días a todos. Gracias por asistir aquí, como siempre digo, a su casa, la casa de todos ustedes, la casa de la innovación, la casa de los estándares. Bienvenidos a GS1 México. Siempre será un verdadero gusto contar con ustedes y aprender, sobre todo aprender mucho de todos ustedes. Estimado Cristian Arturo Zaragoza Jiménez, director general de Información de la Salud, distinguidos invitados, líderes empresariales y expertos en salud digital. Me honra estar hoy para abrir The Issue 2024, un espacio de colaboración e innovación para transformar la salud en México. Queremos acompañar al gobierno federal en la construcción concentrada de un modelo digital innovador que permita a las plataformas inteligentes identificar momentos de intervención y dar seguimiento más cercano a la población usuaria de las instituciones del Sistema Nacional de Salud a lo largo de todo el ciclo de atención. Como entidad neutral que somos, con presencia global, facilitaremos el diálogo entre el sector público, la iniciativa privada y los expertos en la homologación de estándares tecnológicos, otra de nuestras grandes experiencias. Trabajaremos juntos con la Coalición por la Salud de México para lograr un consenso y avanzar hacia un futuro más eficiente y equitativo en la salud, sobre 3 frentes: receta médica electrónica, expediente médico digital y teleconsulta. Agradezco su participación y compromiso. Juntos podemos hacer realidad un sistema de salud más innovador y accesible para todos los mexicanos. Bienvenidos a The Issue 2024. Quisiera presentar ahora al doctor Zaragoza. ¿Me prenden, por favor, la... ¿Me pasas el video, por favor, del doctor Zaragoza? No sé, ¿lo perdimos?
Sí, doctor Zaragoza, ¿nos puede hablar, por favor?
Hola, ¿cómo están? Buenos días, ¿me escuchan?
Gracias. Sí,
muchas gracias, doctor.
No puedo.
Gracias.
Es un gusto ceder la palabra al doctor Cristian Arturo Zaragoza Jiménez, director general de Información de Salud, en representación del subsecretario de Integración y Desarrollo del Sector Salud, Eduardo Clark. El doctor Zaragoza es médico cirujano por la Universidad Veracruzana, especialista en epidemiología por la Universidad Nacional Autónoma de México, especialista en promoción de la salud por el Instituto Nacional de Salud Pública, maestro en salud pública por el Instituto Nacional de la Salud Pública. Te damos la más cordial bienvenida. Adelante, doctor.
Muchas gracias. Reciban primeramente un saludo del secretario de Salud, el doctor David Kersenovich, y el subsecretario, el licenciado Eduardo Clark García. Buenos días a todos los participantes. Para nosotros es un honor estar el día de hoy compartiendo con ustedes y ser parte de este significativo evento, el cual marca el comienzo de una nueva era en el tema de atención en salud en México. Nos encontramos en un momento crucial y aquí agradecemos especialmente a los directores Juan Carlos Molina y Alejandro Trejo por esta invitación, porque estamos implementando modelos de salud digital para el periodo 2024-2030 en nuestro Sistema Nacional de Salud. Y estas comunidades de diálogo, hablar de digitalización en salud, aperturar estos espacios de comunicación efectivo, en donde la tecnología y los datos son prioridad. Es muy importante, sobre todo en los sistemas básicos de salud para toda la población, donde aprovechemos la información histórica para realizar escenarios predictivos a través de la tecnología. Definitivamente transitar a través de gestión, de intercambio y conocimiento mediante el uso de tecnologías es un gran camino. En una población de nuestro país donde tenemos 130 millones de habitantes, un país bioceánico con diferentes determinantes, creo que es muy significativo que nosotros a través de este tipo de eventos hablemos de conceptos como lo son la interoperabilidad, uno de los pilares de la transformación, hablar de telesalud, donde es un componente fundamental de nuestra estrategia para diferentes objetivos a alcanzar. También así del Big Data en salud, donde este análisis de grandes volúmenes de datos transformará lo que podamos entender y gestionar en aspectos de salud. Y la inteligencia artificial, que se ha convertido en un recurso invaluable en el sector salud, desde algoritmos que pueden diagnosticar enfermedades, precisión, sistemas, forecasting, nowcasting. Entonces, quiero agradecer la colaboración, la invitación de todos los involucrados en este sector, pero también decirles que son necesarios los expertos en tecnología y la conjunción con la administración pública para que podamos garantizar que nuestro Sistema Nacional de Salud esté preparado para enfrentar los desafíos y los retos a los que tengamos, y en conjunto con la visión, tener un México más saludable, más empoderado, y pues acaban de tocar temas sumamente relevantes que van acordes con lo que queremos y que estamos trabajando ya fuertemente, consulta a distancia, focalizada, grupos vulnerables, mujeres embarazadas, sin mencionar la importancia de los estándares de calidad, el manejo de datos personales y aspectos éticos y legales. Creo que México debe de marcar el rumbo de lo que sucede en América Latina y debemos de ser un nodo de capacitación para toda la región. Creo que esta apertura, quiero consolidar lo que me ha pedido el subsecretario Eduardo Clark, que refuerce y que decirles que para esta administración la tecnología y los datos son prioridad, y que a través de las diferentes vinculaciones, alianzas y estrategias nos veamos como una comunidad de diálogo abierta, y prueba de esto pues es el estar aquí y el agradecerles nuevamente la invitación. Quiero también decirles que el doctor Kersenovich, el maestro Eduardo Clark, nos han pedido dejar este mensaje de vinculación, de apoyo, reforzar, donde la importancia de los datos son prioridad para tomar decisiones, y pues dejarles este punto de contacto y decirle que nosotros estaremos también mucho en comunicación con el director, con Alejandro Trejo, con Marco Michel, para que sean estos puntos de vinculación y poder estar. Agradecerles el espacio, y creo que lo mencionaba una participante, después de haber vivido el fenómeno más importante de la salud pública de los últimos 100 años, donde aprendimos que el resguardo en casa, las actividades de las funciones, pues nos toca crear a través de la tecnología del piso parejo y de decir en un país en el cual tenemos tanto que trabajar y como les decía, se debe ser un pionero. México debe ser un pionero de la región de las Américas, pero sobre todo también el poder dar igualdad para todos los habitantes. Entonces yo quiero agradecerles esta oportunidad, el estar con nosotros y cuéntenos también como unos aliados desde la Subsecretaría de Integración del Sector y desde la Dirección General de Información en Salud, y es un gusto estar con ustedes. Muchas gracias, directores, que sea un éxito, enhorabuena, y estamos atentos del seguimiento de este evento. Un saludo.
Muchas gracias, doctor. Muchas gracias, doctor Zaragoza. Nos hubiera encantado que estuvieran aquí. Estoy enfrente de 60 o más especialistas del sector médicos, del sector salud del país. Y estamos seguros y convencidos que como COSADIM y como GC1 estaremos apoyando y desarrollando junto con el gobierno federal las iniciativas digitales de la salud por México. Hay un gran futuro por delante y tenemos que poder desarrollarlo. De nuevo, muchas gracias a todos por estar aquí y por su presencia para este evento. Un mensaje coloquial nada más. Tenemos traducción simultánea. La siguiente plática es en inglés. En la parte de atrás tenemos los equipos para la traducción simultánea. Si gustan, están ahí atrás. Muchas gracias y comenzamos. Gracias.
Muchas gracias, Juan Carlos. Muchísimas gracias, doctor Zaragoza. Gracias por su mensaje. Y realmente este mensaje prueba mucho la colaboración que queremos tener con el gobierno. Entonces, creo que vamos en buen camino. Pero bueno, vamos a iniciar nuestro evento y ya lo había yo platicado. Hoy contamos con la presencia de Chris Florey, quien tiene experiencia en la digitalización del sector salud en Reino Unido. Nos compartirá la importancia de la estandarización de los datos, que es un inicio importante para lograr la implementación de la receta médica electrónica y expediente clínico electrónico. Vamos a ver la cortinilla de Chris y para recibirlo con un fuerte aplauso.
Buenos días, and that's about as far as my Spanish goes. I'm very Buenos dias. Buenos dias. That's much, much better. Now I can hear myself. Good morning, everybody. That's for the benefit of my colleagues back in the UK that are hopefully streaming this live. Thank you so much for the invitation. It's an absolute pleasure to be here. I've been involved with GS1 UK for a long time within the healthcare sector, and it's great to see that other nations are on their journey to adopting GS1 standards for the healthcare sector. So, I'd like to tell you a story. So, once upon a time in UK healthcare, and the fairy tale continues. Back in 2007, the Mexico men's soccer team beat Uruguay 3-1 to take third place in the Copa America, but also beat Brazil 2-0 in the group stage. Fantastic. And one of your, and Sultanes de Monterrey took their 9th basketball championship title. And we're talking about digitization today, so it's only appropriate to look back in history. Apple launches the iPhone in 2007, and since then 2.6 billion, I think that's million in 1,000 million in Spanish, have already been sold. Facebook had 20 million users, and now it's over 3 billion monthly active users. So you can see in those 17 years how much technology has progressed. The same year, the UK Department of Health, same as your Ministry of Health, confirms policy support for auto ID and data capture and GS1 as coding standards for products through a document called Coding for Success. That then led to us signing our first contract with the National Health Service in England. And coincidentally, I joined GS1 UK at the same time, which was a great opportunity for me. I never joined to be part of the healthcare team, but I was very excited with the journey that we were about to start. And it's only really in the last 6 or 7 years that I've been a real embedded member of the healthcare team here at GS1 UK. And our approach was to connect for health. And we took the Connect for Health, Coding for Success document that was published at the time, and our approach was to connect for health. And today's theme is collaboration. And it's really important that you understand who the stakeholders are within the healthcare system in your nation. And as much as possible, surround yourself at GS1 with people that can help you make those connections. And I can see already you've made a fantastic start with the issue, now in its 3rd year. It's really important to, as I said, involve everybody. And that's what we did right from the start. It wasn't easy. We were coming at this cold. You probably have the benefit of increased innovation and technology 17 years on, but it will still be difficult. Don't be disheartened when doors are shut and closed in your face, because people move on, so you have to keep going, and somebody else may open that door and welcome you in to that community. So we worked with, of course, GS1 Global Office, because 20 years ago was when healthcare started within GS1. I'm going to wait for the prompter to come back, but it's really important, as I said, GS1 Healthcare. It's important to work with the manufacturers, the suppliers, the solution providers, the providers of the technology that's going to use the GS1 standards, and of course, users and patients. Get them involved as well from the start, because they are our customers ultimately. Those patients are our customers. And of course, we very much need to get involved with the actual healthcare providers themselves. And what's really important, as early as possible, is to get clinical support. We can talk about efficiencies around the supply chain, we can talk about technology, but nothing makes a clinician tick more than knowing things about what they're doing, and so they can better care for their patients. And for me, it's all about the data. GS1 standards are not the solution, they're the enabler. They're the enabler to large-scale data, which can then be interrogated to provide better outcomes for patients. And for us, of course, we're all patients. So the vision started around verifying of products through the supply chain, verifying the right patient, and through inventory management. So it's very much based around patient identification and product identification. and using GS1 standards to link all of those things together. This is our purpose. We harness the power of standards to transform the way people work and live. So every GS1 organisation probably has their own strapline. This is the UK version, but we're all in this for exactly the same aim. We just say it in a slightly different way. And as anybody that knows anything about GS1 standards knows, that everything we do is built on the concept of identify, capture, and share. So this is identifying mostly products, because we've been in retail for 50 years. But as we've moved into healthcare, we're now identifying patients and caregivers. And we're identifying more locations within those hospitals, such as wards and theatres and bed bays and stores. And of course, that information is then captured in a GS1 barcode, and the data is then shared by capturing that, by scanning those barcodes. Our healthcare mission is to improve patient safety. That's an absolute given. Reduce unwarranted clinical variation. This takes us back to what I was saying about clinicians wanting as much data as possible about what they're actually doing. And also to drive operational efficiencies. I mean, operational efficiencies is absolutely in the GS1 wheelhouse. That's what we've been doing for 50 years in the retail industry. And what Scan for Safety did, what Scan for Safety does, we started it in England. We've now expanded out to the 4 nations of the United Kingdom. So we now have a 4-nation approach. And what we're finding is there's excellent work going on in Scotland and Wales and Northern Ireland, which is then feeding back into England, because things have been done very differently. The other nations, apart from England, have learnt from what's happened in England, and they are progressing in certain areas at a faster pace. But they are much smaller nations in terms of their population and their healthcare system. But it's about that collaboration again. It's about those 4 nations working together in exactly the same way that I would expect the different states within this magnificent, massive country you have, Mexico. And how we achieve this mission? So we talk always about person, product, and place. So to improve patient safety, to reduce unwarranted clinical variation, and improve operational efficiency, through the unique identification of every person, every product, and every place. And within the English language, within healthcare, there are lots of Ps. Right person, right product, right place, right prescription. So these are the standards in action. These are the ones that we are mostly focusing on. And again, these fit into that: every person, every product, and every place. And I make no apologies for repeating that, because that is our mantra for healthcare. Patients, of course, are identified using a wristband, a barcode on a wristband, and there's actually a national standard from the National Health Service around using the GS1 data matrix on that wristband and how the data is then captured in that wristband. Products, of course, GS1 standards are used for products. And we've been fortunate in that our journey has coincided with the FDA UDI regulations and with the EU Commission UDI regulations. And there are other nations, of course, that are introducing their own, have and continue to introduce their own regulations around unique device identification for medical devices. So the NHS timeline coincided with that. So we were talking to manufacturers from 2 angles. It's a requirement of your trading partner in exactly the same way as with retail. It's a requirement of your trading partner. It's not a legal requirement, it's a trading partner requirement. But we then had the backup of it being a regulatory requirement. And for the first time, and I've spoken to many medical device manufacturers who have been supplying the NHS for decades. It's the first time there's actually been some real drive behind the adoption of GS1 standards for medical devices and for pharmaceuticals. Of course, there are the European Falsified Medicines Directive has been a big driver for the use of GS1 standards in the UK and in Europe. And we also have assets. There's a lot of work now going on where GS1 standards are used for the unique identification of individual assets, the GIAI. And we're starting to see a lot bigger rollout of radio frequency identification technology. So that you have real-time location services for equipment as it moves around the hospital. And of course, we have places. The GLN is used to identify the place within the GS1 standards, but that's not really that important. What's important is it's a unique number. I've been around hospitals, and you go and look at a door to a ward, and it'll have four labels on it with different barcodes, with four labels with different numbers in the barcodes. Because what you have is different departments within the hospital wants to identify that space. And they go and put a different number, and put a different label on. What the GLN does, what GS1 standards do, is eliminate all of that. Everybody uses that same number. So which means that all of those different systems can, of course, then talk to each other. Now, GS1 standards in healthcare, globally unique data standards, and again, it's very much data. It's all about the data. And GS1 standards are system and device agnostic. It doesn't matter what systems you're using as long as it can process the GS1 standards. So we ensure as much as possible that any solution providers that are working with the healthcare service in the UK have solutions that can process the GS1 standards. But we also have them as partners for them to advocate the use of GS1 standards. They really have to be champions for the GS1 standards. When we use the term partner, we mean it's a partnership. It's not just the excuse for them to get their name on our website and use a logo on their website and use us as a marketing tool. It really is about collaboration. Data interoperability. Again, it's about sharing that data in the same language across different systems. And you're capturing data in real time, particularly at the point when it comes to the point of care. So what we see is that people capture data after the event. So they'll have a book that has the barcodes for something in it, and they'll go and scan those a day later, 2 days later. But that's not real time, and that's not accurate. It has to be, and it must be real-time data capture. So it has to be point of care scanning. And there are lots of programs going on in the UK to increase the amount of point of care scanning that is taking place. And when we talk to the healthcare system, we talk about the 3 core enablers: patient identification, catalogue management, and location identification. So again, we're using GS1 standards, as I mentioned, for the wristband, for the patient ID band. We're using the GTIN as a primary identifier for products. And we're implementing global location numbers for not just physical locations, but to identify the organizations that are doing business, that are communicating with each other. So we'll come on to that in a few moments. Catalog management, having your products that you buy uniquely identified using GS1 standards and in a catalog means that you are ordering the right product from the right customer, from the right supplier. And GLN's come into that because within these systems, you should have global location numbers to identify those suppliers. Because a lot of particularly within the pharmaceutical and medical devices industry, there's a lot of acquisitions mergers, demergers, and names change quite often, as I've found in my experience, particularly in the last 10 years. So how many different names are there for the company Abbott, or for 3M, or for Johnson & Johnson? Now, we all know them as those particular names, but if you dig deeper, they've got lots of different names for different subsidiaries of that company. And that's just confusing, totally confusing. I had a conversation with one of our members. They're Braun Medical. Not B. Braun, Braun Medical. They receive orders from hospitals that are intended for B. Braun. Now, since they started using a global location number to identify themselves, they're not having to phone up the hospital and say, oh, I'm sorry, but you've sent the order to me, it should have gone to B. Braun. That's just a very simple example of how using GS1 standards can make the whole system so much simpler. And we have a program on right now where the NHS supply chain, which is the biggest distributor of medical devices in the UK, is with funding from the Department of Health, is rolling out inventory management systems to 20 hospital trusts. A trust can be one hospital, it can be several hospitals, and there are about 150 trusts across England and probably approaching 200 across the United Kingdom. So there are inventory management systems in place already at many of these trusts, but for the system to work as well as it should, as well as it could, then of course it relies on everybody using this. But some of the equipment you need, a device that you need, is not available, or somebody's gone to scan it and they realize it's expired. Imagine being able to look into the database, a central database, and realizing that same product is available from a hospital that is 20 miles away. You can have that medical device, that implant delivered, and that surgery the following day can go ahead as planned. And just imagine, it doesn't take a lot of imagination to work out how much better the system is when things are done when they should be done. You don't have people standing around doing nothing because something's been cancelled because you don't have the equipment that you need. And at the beginning of today's session, talked about the importance of healthcare providers, of making sure you have the skilled people and enough of those skilled people to provide the healthcare that you want to in Mexico. It's exactly the same in every country. So if you can make sure that their time is better spent providing care by making sure every surgery that is planned, it takes place, or if you can cut down the amount of time that a nurse spends on stock takes, on reordering, on looking for things, then you straight away you have more time returned to care for those patients. Location identification, as I said, global location numbers can be used to identify physical locations, as the name suggests. At least it suggests that in English. But they are also used to identify organizations. And here's some ideas of the importance of having unique identification of physical spaces. Product recalls, knowing exactly where that product is in the hospital when a product recall hits. So the GTN, of course, lets you know whether you've got that product or not. The GLM will let you know where that product is because you scan that barcode on the product at the point into the storeroom when it's being delivered. You know where things are. Again, I just mentioned it, deliveries. Deliveries are going into those locations. Orders, you're using GLNs to identify your customers and your suppliers. Asset tracking, if you're not using RFID, you can scan the asset tag, you can scan the GLN at the physical location. And of course, you can also have patient location, real-time patient location information, because as you're moving patients from one location to another, you're scanning the ID band, and you're scanning the GLN at the physical space. The benefits of inventory management: real-time product location information, accurate product consumption data, improved stock control, reduced wastage, product expiry alerts, automatic stock reordering. Now, this is nothing new in the world of GS1. It happens in retail, and has been happening in retail for very many years, for decades. What we're doing here is we're taking this into the healthcare system, and once you start to look at it, you realize how important it is in terms of delivering better care for patients. It isn't just about the monetary side of things, being able to ensure that your product gets to the retailer and onto the consumer in good time. It's about improving the care that hospitals provide to their patients. E-medicines. Again, it's about joining everything up so that you are, within electronic medicines, you are ensuring you have the right patient because you're scanning the wristband with the barcode on it. You're scanning the GTIN for the right drug. And all of that means you've got the right dose, right route, right time. And you can, once these things are in place, you can start to do other things with it. So now we have cabinets that won't open unless you scan a patient's wristband, and that drug that's prescribed to that patient at that time is actually available in that cabinet. So it won't open otherwise. And then when you open it up, you have to scan the product barcode again. Closed loop medicines. So we are working with the Dictionary of Medicines and Devices in the UK, who have GTINs for GS1 identifiers, the product GTINs in their system to identify all those medical devices and those pharmaceuticals. And that information comes from, that information comes from the manufacturers. And then that is then used to enable electronic prescribing and medicines administration, EPMA. So you have that full closed loop where the patient comes in, it's assigned a wristband, and through the patient's journey, whenever there's medicines administered, you have that closed loop of scanning from the patient to the drugs. EPRs, electronic patient records, that's a term that we use in the UK. Another term is electronic health records. And again, as I mentioned, this is about data captured at the points of care. So you're scanning the location, you're scanning the caregiver, you're scanning the patient, you're scanning the assets, you're scanning the devices, you're scanning the medication. And all of that provides a rich set of data about that episode of care for that particular patient. Once you have that information, you can then start to share that information with other organizations. You can then start to interrogate that data, again, to reduce unwarranted clinical variation and improve patient safety. Inpatient monitoring, theatre management, document tracking, pathology management. I'm not going to read them all out, but yeah, as somebody once said, once GS1 standards are in place within the healthcare system, you're only limited by your imagination of what it can actually do in terms of improving efficiencies in patient care. Benefits. I think I've spoken about some of the benefits as we've been going through here today already. Financial benefits. Of course, financial benefits are important because healthcare is expensive. It is expensive. As we're living older, of course, aging population, more and more of us are living longer, but we get more and more illnesses as we're living longer. So year on year on year, healthcare is getting much more expensive. So we need to find ways of saving money. Now, when we first approached the healthcare system in the UK 20 odd years ago, we said, look at GS1 standards. Look what they can do for you in terms of saving money. Doors closed. Not interested. We have lots of money. We could argue that they never have enough money. But so we changed our approach, and we said, actually, look, this is what GS1 standards could do for you in terms of improving patient care. Hello, what did you say? Suddenly they're interested. But of course, we can now that we have got them hooked on the line around patient care, we can then have those conversations around the financial benefits, because they trust us now, and it was never us selling them any services. It was all about us trying to help themselves to improve patient care. But we can take any of these, but let's just look at one of those. £38,000, and I'm sure the translator will be able to put that into Mexican pesos for you, worth expiring stock was returned to the manufacturers. So these figures are taken from the Scan for Safety Demonstrator Site program, where 6 trusts adopted the standards and reported back on their findings. So that's across, that's in one of those 6 trusts. Imagine expanding that across all of the theatre stores, in all of the hospitals, in all of the UK, or in any country. You can see the amount of financial benefits from just doing that one thing. Another one which is quite interesting, the staff cost of a recall incident. So the staff cost of a recall incident was significantly reduced. It isn't just about the staff cost, because it takes less time. Again, you're returning time for that person to care for patients. Because in the NHS in the UK, a lot of those tasks are carried out by clinicians, because those tasks, in my opinion, shouldn't be carried out by clinicians in the first place. But if they are doing it, let's bring down the amount of time it takes for them to actually carry out those tasks. Operational benefits, I just mentioned it, 140,000 hours of clinical time released to care. That's per year. That's per year, and that's for one hospital. And myself and my CRS worked it out yesterday. In the Mexican healthcare system, with the 6-day week, that works out to be the time of 56 nurses in one hospital per year. That's extraordinary. Imagine being able to release that much time back into patient care. What else have we got on here? Things like ward transfer times. Because you know where the patient is, you're transferring between, because you're scanning and not writing things down, and you're using that simple technology. It just reduces the time. We know how much time it takes when we go to a supermarket and a barcode doesn't scan, and we then have to stand there trying to type in that number. How long that takes us? Whereas if it works, it's moments. And we can just relate those things that we do in our daily lives. If we relate those in terms of GS1 standards to the healthcare system, it's very, very easy to understand how quickly you can make changes. Safety and clinical benefits. We've already talked about the average time for product recalls, really important. Product recalls are really important. But also, if you've got the information in your systems and that UDI or that GTIN is in the recall, and you can plug that into your systems and ping, it tells you where those products, if you've got those products, where those products are. If it's an implant, okay, do I need to recall those patients? But I know who those patients are, who are walking around with that implant. During the pandemic, there was a recall of ventilators. Now you can imagine nobody wants a ventilator to be taken away from them during a pandemic in the hospital. But it's important, if there's a recall, if there's something wrong, that you take it away. So you need to, as quickly as possible, you need to get those ventilators out. Because the clinicians want to use those ventilators, they want to hold on to them. But you've got to take them away, so you need to know exactly where they are. 100% recall. The benefits of point-of-care scanning. Of course, there's a reduced risk of manual error. Again, going back to the supermarket till, I'm typing in a 13 or 14-digit number. or sometimes it's when they've got the labels on for reduced items. It could be 18 digits long. How many times did it take me to type that in to get it right? Positive patient ID, of course, it's the right patient. That's really, really important that you actually, the procedure is being carried out on the right patient. Of course, it's accurate and trusted data. It's about trusting the information that's in front of you. It's about having the confidence that what you're doing is absolutely 100% right. It's quick and easy. Already talked about releasing time to care. And then particularly in, not so much necessarily within the UK system because it's mostly public, but certainly with the private healthcare system, when it comes to insurance, absolutely you want to make sure you've got, as accurate as possible, you've got patient level costing, so you know exactly how much that procedure cost. But why now? I say why now? We've been doing it for 17 years, but why now? It continues, as I said, the fairy tale continues, and it is a fairy tale that we've come so far in the UK in terms of adopting the healthcare system, adopting GS1 standards. Digital technology has moved on so much in those 20 years. And it's almost, why aren't you doing it? It's not a case of why now, it's like, why not now? I have conversations with friends, and I tell them that we're doing this, and they go, why is this only happening now? Why I would expect that when I go for an operation, that the surgeon knows who I am. They're confident that they are operating on the right person. That they're confident that they're using the right equipment. They're confident they're using the right medication. That should be a given within the healthcare system. And of course, it's interoperability as the whole system gets more and more complex. And of course, we need the full traceability. We talked about recalls. It isn't just traceability of the products, it's also the traceability of the patients as well. And we've expanded it out to the whole of the United Kingdom. We started off in the NHS in England, and we're not a big enough team to have gone out there to try and get the other nations to come along on that journey. But eventually they came to us. They came and knocked on our door. So we then went out and worked with them. And they're doing some great work, particularly around inventory management and point of care scanning. And this is just a brief snapshot of the Scan for Safety journey. It was off of a mandate that happened 10 years ago. So I've been having these conversations for 10 years, and we'll continue to have these conversations probably for another 10 years, unless I retire to Greece before then. And the Scan for Safety program was introduced a couple of years later. Now that was funded, that was great, because it was funded centrally by the government. And I think, based on the return on investment, the government then turned around and went, it's a no-brainer. We don't need to give money to the hospitals to do it. We've proven that it works. We're going to let them do it themselves. I think that was a mistake. I think they probably should have continued with funding, and it would have moved much, much faster. And now we find that more and more publications within the healthcare system advocate for the use of GS1 standards for lots of different applications. Now, the key Scan for Safety benefits, we've talked about the benefits in more detail. So, complete traceability, speedy and accurate recall, reduction of drug error and never events, something that should never happen because it shouldn't happen because you have the processes in place for it not to happen. Let's make those processes more robust using GS1 standards. Improving routine observations and patient identification. Reducing the time it takes for routine observations means you can reduce more time to care. Imagine it takes a nurse 10 minutes to 5 minutes to do an observation with a ward of 20 people. Reduce that to 2 minutes, that's three minutes that's an hour. It's an hour you're reducing, now an hour's time you're spent not just taking routine observations, but doing other things to provide patient care. And of course, cost and efficiency savings. Happier and more efficient staff. It takes a little while for the caregivers to really understand and adopt and embrace GS1 standards, but once they see what it can do for them, they're advocates for it. We can use them to speak to their peers. And this is repeat of the slide from the beginning, because for us, it's always been about collaboration. And it has to be about collaboration. You have to get everybody on side. Of course, it's nations in rolling out these types of things. So they have experience that they can share with you. And of course, it's really important to have those solution providers on side because they're the ones that are going to ensure that once you start to roll out those standards, that the systems are in place to be able to use those standards. Thank you very much for listening. I think we have some time for questions.
Hola, hola. Thank you very much, Chris. And now we are going to open to questions, please. If you have a question, you can ask them in Spanish if you want, or if you prefer in English, it's okay, because do you have your translator? Okay.
Take it.
Let me.
Chris, thank you for the conference. I'm pretty sure that all that are in this room are very committed with the health system and, of course, to grow up this vision to have a traceability in all the products and, of course, medical devices. I represent the National Association of Health Providers in Mexico. Most of them are supporting medical devices. And I have a big question, more complex than what is happening right now in UK or maybe United States. In Mexico, we have more than 4,000 of sub-distributors. So the main channel that distribute the medical devices in Mexico is running by small companies or medium companies. So as you said in your presentation, there's a big point that must have the collaboration of everyone's, you know. Thinking about the privacy of the data and, of course, who's having the medical devices in their warehouses and, of course, the traceability of the products instead from the manufacturer through the hospitals or the end users. How can we involve these distributors? Because I'm very sure, and I have been speaking with a lot of them, that they don't want to get involved with this system because then the manufacturers will have all the information, who's the customers, who's the medium distributors that is having or running the distribution channel. And of course, there's a big challenge because we need them, you know, in Mexico, we need these logistics of the small distributors to go to the end users. But there's like a very complex thinking of how can they share this information to keep this traceability. Have you been thinking on that? Have you been working in some country that is similar to Mexico with a lot of sub-distributors? And how can we involve them to think that this is a good system that includes them into the distribution channel of the medical devices?
Thank you very much for the question. We have a very, as you said, we have a very different model within the United Kingdom because we have one major distributor, which is actually government owned and is overseen now by the government. So that makes things a lot easier because we're having a one conversation. But what is great about GS1 standards is that you don't need to know who owns anything or what the price is. That information that you're sharing between the manufacturer and the distributor and the healthcare provider. Does a manufacturer need to know who's buying their products? They don't. You have that traceability because you have that traceability within different systems. You can trace it back through the distributor. Okay, so in a recall incident, for instance, you get a recall, a field safety notice, as it's called in the United Kingdom, and it will list on that field safety notice. It will list the distributor. It will list the manufacturer. It will list the GTINs, the product identifiers, on that. Hopefully, if they're doing things as they're asked to do, and that information is shared with the regulators, and then subsequently shared with the healthcare providers. There's no issues around data protection and sharing of commercially sensitive information within that traceability system. So I would say to those distributors, you're probably already using GS1 standards within your systems for logistics. You're probably using GS1 standards on a pallet label when you receive the goods from the manufacturer, which you then split down and send out to your customers. You're probably scanning those barcodes on those products already. So you already have that information in your systems. So I don't see that there's any issue around confidentiality or sharing of commercially sensitive information within these traceability systems. Talk to the distributors. I'm sure there are trade associations for those distributors, and through those trade associations, get to those and understand what those distributors are doing in terms of using GS1 standards. Because when we first started this 20 years ago, the percentage of medical devices that had GS1 barcodes on them was relatively low. In a recent survey, 95% of the medical devices in a particular hospital had GS1 barcodes on them. And I expect the situation to be the same for the majority of products here in Mexico. For local manufacturers that haven't come on that journey yet, perhaps not. One of my first roles within GS1 UK was to talk to those small to medium enterprises and bring them on the journey with us. Okay, yes, they need to become a member. There's a small charge for that. But it's about selling the benefits to them, because why are you in the business of manufacturing medical devices? For most companies, particularly small companies, it's not about the money. It's about you wanting to provide better products, innovation for the healthcare system. So it's easy for them to come on board. In my experience, if there's a national program to back it up, and they can see what's happening elsewhere and the benefits it's creating, I don't see there's any problem with them coming on board.
Another question? The microphone? Okay.
Can you hear me? Yeah, thank you. Well, hi everyone. Paulina Gonzalez from Farmas Guadalajara. I have one, this has two main issues. One about prevention and the other about, yeah?
Sorry, I thought you were going to speak in Spanish. Are you speaking English?
Yes.
Yes, sorry, it was being translated to Spanish in my ear. Sorry, please start again. Thank you.
Okay.
French?
Yeah, English is great. Thank
English
you.
is okay.
We're talking here about how to address the conversation. It's a fairy tale, what you're telling us.
Yes.
It's really a fairy tale. How can we address that conversation when we have so many barriers according with legislation? How can GS1 help us to break those barriers in order, you make a great point. How are we have to, one, the prevention, which is cheaper to the patient, cheaper to the country, and allow us to live longer with a better quality of life. And then we have on the other, the devices when we already have the illness. And we have medicines upon both to maintain other quality of life or just to at least keep you alive. But we have barriers in all of these stages. And we're talking about standards and data and how that data could allow us to ensure standards on the worth of the patient, on the health of the patient, to help them. But right now, we don't know how to address those conversations, and I think the topic is very it's alive to all of us. Either you are a retailer, either you are a pharmaceutical, either you are a distributor, even you are a hospital. We are not connected in between us. And this is and the government is not helping us to keep that connection. On top, keeping the privacy or the safety of the data, but we are not covering the health of the patient in the ecosystem. How do you, as GS1 in UK, address that agenda? And and what's your recommendation for us to go into that direction so each of us can really put efforts on what we want, that is provide the health of all the Mexicans 1/3 of Mexicans have diabetes, and we're going to live longer with a worse than even, I don't know how to say, like the quality of life that we're living to our kids, it's worse than what our parents lived to us. How do you address that conversation?
Thanks for the question. And one thing I will say is be patient. It will take time. As I said, our approach initially was very different to what it became. And it's about finding out who are the people that you need to have those conversations with. This organization that's been created is a fantastic start. It's not something that we had when we started. I think we were just in the right place at the right time, to be absolutely honest with you. There was a solution to a problem. There was a problem that needed a solution at the time, and we approached the people that we knew that we employed new members of staff that had experience in the healthcare sector, and they were able to put us in front of the right people. So that's really important. It's about using the network to get the right people on your side. As I said, there was a problem that needed a solution at the time. So we were very fortunate. So it is difficult, and it's continued to be difficult for us. We've made a lot of progress, but a lot of progress, really, 17 years, 20 years, we've still got a long way to go. And for us, sitting as GS1 UK and as GS1 in general, for us, it's what we call a no-brainer. Surely, why would you not do it? But you're right, you need to start somewhere, and I think this organisation that's been created is a fabulous start. And I really do look forward to collaborating with you going forward as GS1 UK, and also, any other introductions that we can make to other people around the globe to help you on your journey. But it will be difficult. It will be difficult. You just need to be patient and understand that it takes time. Getting people to talking GS1 standard is not the answer. That's not the answer. Talking about what GS1 standards can do is the answer. Because if you start to talk to people about barcodes and identification numbers, they very quickly switch off. I'm glad that you guys didn't, by the way, but they very quickly switch off. It's about, you need to talk about what it can do. And there is proof. Okay, they're very different healthcare systems, but you can take those benefits, those proven benefits, and you can plug them in to any healthcare system and realize and get some figures out the other end and use that information to sell the dream, to sell the fairy tale that is GS1 standards being used throughout the healthcare system, throughout the globe.
Tenemos una pregunta por allá también. Vamos a continuar. Adelante. ¿Va a ser en español o en inglés para?
Español.
En español. Ok, entonces sí te puedes, if you can put your headphones.
Bueno, gracias. Felicidades y gracias por compartir el conocimiento. Soy el doctor Santos Reginus Canga Sánchez, soy médico militar, ginecobstetra, ginecólogo, oncólogo y asesor en sistemas de gestión de calidad en salud. Entendemos dos preguntas claritas. ¿Cuál es la interacción que tiene el expediente clínico electrónico con el expediente gubernamental, si es que hay un expediente gubernamental? Y la otra pregunta tiene que ver, voy a poner un poco de contexto. En nuestro país hay 136 millones de personas que son atendidas a través de más de 5,000 hospitales y más de 20,000 unidades de salud, y las tendencias, por ejemplo, de cáncer, tienen una tendencia de tasa de mortalidad desafortunada. Nuestro país está transitando hacia el acceso universal en salud, en términos de lo que marca la OMS de la atención primaria en salud. Entonces, vimos en su presentación que el recurso clave para lograr el propósito que nos mencionó es utilizar estándares para transformar la forma en que la gente trabaja. Entonces, la pregunta es, dado que no vi los estándares que tienen que ver con la macro y la mesogestión, lo que necesitamos en nuestro país es que se automatice la medición de esos estándares que tienen que ver, por ejemplo, porque no tenemos esa información en tiempo real, sobre la capacidad de los sistemas de salud, de las instituciones de salud, para asegurar el acceso oportuno a los servicios. En cáncer, sabemos que este intervalo tiene que ser en menos de 3 meses, y eso en nuestro país solo se ocurre en menos del 15% de las ocasiones. Pero además, nuestros establecimientos de salud operan en condiciones no controladas. No tenemos adecuadamente implantada ni controles de calidad en los establecimientos, mucho menos en los aparatos. Por ejemplo, cerca del 40% de los mastógrafos no funcionan y no tienen programas de mantenimiento, hay como 1,500 en el país, y no tenemos adecuado grado de implantación de una cultura de mejora continua de los responsables a nivel nacional y estatal. Entonces, cuando preguntamos sobre el desempeño de las redes de servicios de salud o de los establecimientos o de los servicios específicos, no existe. Es más, casi seguro, ni siquiera lo miden sistemáticamente. Por eso, la solicitud es que se incluya en los estándares de GS1 estándares que tengan que ver, que faciliten la evaluación del desempeño de las redes de servicio, de los establecimientos y de las condiciones de operación de la infraestructura. Esto es, ¿cuántos de los 6,000 hospitales que tenemos están certificados? Sé la respuesta, ninguno. Ojalá y puedan incluir ese estándar de gestión, de macrogestión en los estándares de GS1.
Thank you for the question. I'll take the first one, which, if I remember, was what access does the government have of the information in the electronic patient record for each patient? Well, you could argue that those procedures take place within the National Health Service, which is funded by the UK government. So you could argue, well, they have a right to that information. Anonymized information. So it's not about Christopher John Flory, who lives in Tottenham in North London. It's about what's happened. It's about my episode of care. And one example of a government-funded system is the Outcomes Registry. And the Outcomes Registry mandates the use of barcode scanning at the point of care. Now, that barcode scanning includes the patient wristband, and it includes the caregiver, and it includes the product. And this is mostly, this Outcomes Registry is mostly around implantable devices, because we're going to be walking around with those devices, so it's really important to know who's walking around with those devices. So that information is in my individual electronic patient record, my electronic health record. But the information that's shared to the government-sponsored and government-funded registry is anonymized information. And as information increases around my recovery rates, or me perhaps having to have becoming ill because there's something wrong because the implant is something wrong with the implants, or the operation hasn't gone well, that information again feeds through to the Outcomes Registry. And I'll go back to what I said earlier. It's about that data, having that data, and being able to interrogate that data. And the more data you have, the better information you have, and the better decisions you can make around improving that patient care. Your second point, I'm not sure that GS1 standards are there to improve some of the things that you're talking about. GS1 standards enable the capture and sharing of information within the healthcare system in the United Kingdom is mostly for acute care. So it's at the point of care. It's not about diagnosis. It's about when the actual care takes place. Now, it's taken us 17 years to get where we are with acute healthcare. And we're now starting to look at how GS1 standards might benefit in the community. out in the community outside the hospital environment. So there may be opportunities there for GS1 standards to help with those, with some of the things that you've mentioned. But the easiest, and I use that term loosely, the easiest way into the healthcare system is to look at acute care, because it's procedures that are taking place and it's all about a closed environment where you've got a theatre, a nurse, a surgeon, a product and a patient. So absolutely, let's keep an open mind about how GS1 standards could help in other areas, but I think concentrate on what's easiest first. I know it's not it's perhaps not what we want to hear, because, as you say, if we can diagnose cancer much quicker, of course, people survive. The survival rate is significantly increased. I just don't see, in my imagination, I can't imagine how GS1 standards would help with that right now. But thank you for the question.
Por cuestión de tiempo tenemos espacio para una pregunta más. ¿Hay alguien más que quiera preguntar? Ya, acá tiene el micrófono. Nos vamos a dos. Lo que pasa es que han sido un poco largas las preguntas y largas las respuestas, pero vamos con dos preguntas más.
Hello, Chris. Thanks for your talk. I'm Dr. Ramirez from Equitas Medica. During your talk, you mentioned...
Sorry, can you put the microphone? Yes.
Better here?
That's
okay,
much better.
yeah.
Thank you.
Yeah, sure. During your talk, you mentioned that you saw like a 76% reduction of medical errors, meaning in wrong prescriptions, I think. And you mentioned how GS1 was integrated for the right patient and the right drug. But I am curious, how did you work the part of like the right dosage? I think all of us who have worked when providing the service to a patient know about a case where someone gave like 3 times the correct dose and the patient was like asleep in the best of the cases. How did you work that around in the context of the GS1 standards?
Yes, thank you for the question. A really good question. And I think if you would have noticed that there wasn't a GS1 standard against dosage on that slide. Because it's very rarely do you have a GS1 barcode on on the actual blister pack for individual tablets, for instance. And what we are finding, where that is not done where that's not put in place by the manufacturer, we're finding that hospitals are actually purchasing robots that will actually cut up the blister pack and put a barcode on it automatically. That's not using GS1 standards, but that's an example of the healthcare industry, the healthcare providers finding a solution because the manufacturers are not ready to do it themselves yet. And that in itself can help with the right dose, because you're not giving multiple tablets, you're giving one tablet. And each of those little GS1 2D barcodes on the blister, on the individual blister for the tablet, identifies that particular medicine and that particular dose. But of course, there's also, what GS1 standards doesn't do is completely eradicate human error. It only enables improvements. You will still have never events. I mean, there are an incredible amount of incidents where the wrong drug is given or the wrong dose is given to a patient in a hospital setting. Thankfully, the vast majority of those are benign. They don't. There's no adverse effect. Again, so it's about, as much as possible,